of overall just feeling exhausted. Um, Oops, it blanked out. Sorry about that. So really being able to recognize, what the health impact is on the mental health, or, is there a mental health component going on, or is it just physical, or is it combined, and is it both? And that's really where the whole team comes in and works together. Anxiety is another thing that we screen for. Persistent worrying, anxiety, feeling nervous, feeling on edge, having thoughts racing through your mind that you can't kind of let go, difficulty handling the uncertainty of what is going on, whether it's a test at school or friendships or health or a child's health. There's so many different ways of being anxious that it presents, and really being able to have that conversation, frankly, and explaining also what anxiety is. Because a lot of times, especially with preteens and teenagers, when we talk about anxiety and depression, they kind of just look at you like, I don't know what you're talking about. What do you mean? Or a lot of other times when I just say a blank statement, so what do you think about anxiety? They'll be like, I don't have it. I'm good. But then when I start explaining what it means to feel anxious, what are some symptoms that we look for, I start hearing, yeah, that goes on. Yeah, that's happening. And so being able to bring it to their level, to be able to have that conversation is so important when we're factoring in our screening tools. So we frequently use screening tools in clinic, and the CF Foundation several years ago wanted clinics to start implementing it. And so typically it's once a year, patients 12 and older and their caregivers get screened using depression and anxiety screenings. Here in Alaska, we use the PHQ-9 and the GAD-7. And then we also start screening overall, from day one, talking about behaviors, talking about moods, talking about troubles, and really kind of just normalizing the conversation. When we look at COVID, COVID's been really hard the last several years, but the last year. But I think the positives that come out of it, and I really try to look at the positives because I think it's so important, is that it's opened up a conversation about anxiety and depression and normalizing it. So that has actually been, I think, really beneficial in a society as a whole. So I do have a short video that, hold on, that I was going to show that the CF Foundation put out a few years ago, that is on mental health and talking about one family's experience. So,
my eldest is Maylee, and she has CF, and my youngest is Elsie, and she does not have CF. I had a very different experience than most families because Maylee was diagnosed at 3. And so those first 3 years of her life were very terrifying, trying to figure out what was wrong with her and not having answers. And so when Maylee was diagnosed, while cystic fibrosis was a terrifying label to be given to her, there was also a feeling of relief that we actually had a place to start working now. We had treatments, we had opportunities to help get her back to being healthy. The emotional aspect of CF is probably the most impactful aspect of everything. It's that feeling of being out of control, not being able to fix something. No one can go through what we go through every day, watching our children in pain or struggling to breathe, or being the one to hold them down for a procedure and not feel some sort of anxiety and depression. There would just be nothing in you if you didn't feel that. And so it doesn't matter how amazing your support system is. It doesn't matter how amazing, all the other moments in your life are. There are these key points within the CF life that absolutely rip you apart. with all the hurdles that we have, that if you're not healthy, you cannot take care of your children. And I think that needs to be the focus, is we are their role model for how they'll be caring for themselves. I think that mental health screening for both patients and caregivers should definitely be something that just starts from the beginning. Having support systems in place that allow for caregivers to really unload about that feeling and have ideas as to how to kind of push through those times, right when those first clinic visits happen, that it's just implemented into part of the routine maintenance. I mean, how's your lung function? How's your BMI? How is your mental health as well as your child's? Just to kind of have that screening be a part of all the other screenings that happen, so that when a red flag comes up, it can be addressed in a very non-confrontational environment that makes everyone feel like it's just part of the care. I think normalizing the emotions that accompany the diagnosis and the disease progression is the first kind of point to get back to where I need to be the best caregiver for Maylee.
So I think that really shows, hold on, I'm going to close this really quick so that it doesn't. So I think that really shows the importance of why screenings occur and why conversations occur. But I think more what I found overall through my years of working with families with children and young adults with chronic illness is really, it's the relationship, no matter what. It's that relationship of showing that somebody cares, somebody wants to know, hey, how am I doing? Not just from a physical aspect, from a medical aspect, but how are we coping? What's going on in our lives? What are the good things? And being able to talk about all the wonderful things that are happening in life, but also then what about the hard things? Is so important. And I think it's a general, just kind of an aspect of what we do here in Alaska. And that's the next part of the presentation that I wanted to go over, was just the differences that we have here in Alaska. A lot of times people think about Alaska and they think that, we're very remote, which we are, and that we don't have a lot of things, or we don't have big cities, or I don't know. I've heard all kinds of things. Do I live in an igloo? Do we have cars? What does it look like? So Anchorage is a huge city. And we actually have a pretty impressive mental health system here, just because for years Alaska has really dealt with, mental illness, suicide attempts, substance abuse, child abuse. And so there's always been a very active role in discussing that and accessing services. But then on the CF team, what we're able to do and what we've been able to do is kind of focus it in more for patients across the state. So we're a small team. We have about 55 patients in clinic, and we have clinic once a week. But we are located near each other. And so we're constantly having conversations about, what we can do to improve clinic, what we can do to help families, who patients or families, what are they struggling with? And so when I returned to clinic about a year ago, after taking a couple of years to focus on a different chronic illness, I decided that I wanted to provide more mental health services to our clients, to our patients and their families, because so much of it is about the relationship. And so we began actually offering counseling in clinic. So now I have two roles where I'm the social worker in clinic, and then I'm also now the mental health clinician. Obviously, patients have the ability to make a choice, and we talk about, what's in their best interest. Is there a therapist in the community? What are they needing help with? But they also are given the opportunity that if they would rather meet with me so that they don't have to explain their diagnosis and what their life entails on a day-to-day basis, but that we can definitely make that happen and make that work. COVID has also opened up so many opportunities in terms of telehealth for us across our state. In the past, clients in remote communities have really struggled with accessing mental health because they are either cut off from the road system, or maybe they have Medicaid and they can't get a Medicaid provider, or they live an hour from town and making that trip is just too difficult, or the weather is bad. And so being able to have telehealth visits has really opened up so many opportunities for our patients and families to say, hey, let's see what we can do. I do want help. I want to be able to focus on my mental health, and working on those aspects so that then we can work on their general treatment. So that was my general presentation today. Sorry, I feel like I was a bit rushed, but I don't know if anyone has any questions or not.
Thanks. And if anyone does have questions, please put it in the Q&A box. We'll give it just a second to see if we have any. Thanks, Stephanie. I think everyone can agree what an important topic this is, and that, now more than ever having, oh, we have a question. Let me pop over. We have a question. How long have you been working at the clinic?
So I started working at the clinic in 2015 as the CF social worker. Before that, I would fill in. Our clinic, the way that we're based up is we're a pediatric subspecialty clinic, but then for cystic fibrosis, we are a multi-age generational clinic. And so I was already working with diabetes clients in that clinic when the CF position opened. And so I moved into that in 2015 and managed that with about 8 other chronic illnesses at the same time, clinics. And so in 2017, we had another social worker join me, and just due to the infrastructure and stuff, I had to make the decision to leave. So I did pediatric oncology full-time for about 2.5 years. And then I returned. The other social worker ended up leaving. And so I returned to clinic about a year ago. And when that happened, we had a big discussion about why. Like, do I want to return? What does it look like? And I always loved CF. I think it was one of my favorite clinics, and I was really sad to let it go. But I think the most important thing for me in deciding to return is because I had the relationship. It meant that the families didn't have to establish with someone else. They knew me. I knew them. The majority of them. I knew the histories. I knew what so many had gone through in life, and so it really made the transition seamless, and really allowed that seamless transition into discussions about mental health and coping right from the beginning, rather than having to establish a relationship again.
Definitely having you there, someone that they trust, it's so important. And, 2020, the pandemic has been tough. I think this is so important more than ever. And so having you willing to come on and speak with us today was so needed. We're so grateful for you.
Thanks.
All right, we're going to head over now to Dr. Mirjani. She's going to be speaking on the importance of screening for CF diabetes. Dr. Alina Mirjani is an assistant professor of pediatrics at the University of Washington and a pediatric endocrinologist at Seattle Children's Hospital. Dr. Mirjani has clinical and research interests in CF-related diabetes and endocrine disorders. She's part of the multidisciplinary CF team at Seattle Children's, through which she provides diabetes and endocrine care for CF patients. She's also part of the Envision program, which is sponsored by the CF Foundation to train emerging leaders in CF endocrinology. Thanks for speaking with us today, Dr. Mirjani.
Thank you very much for the introduction, and thank you for having me today and giving me the opportunity to present to the community about the importance of screening for CF-related diabetes. So I'm going to share my screen first. Okay. Okay, are you able to see my slides or no? Am I sharing the right screen?
Yep, we can see.
Do you see the full slide or the part of it?
We see the full importance of screening for cystic
Okay.
fibrosis related diabetes.
Great. Okay. So I'm going to first talk about the prevalence and significance of CFRD, and then discuss the difference between CF-related diabetes and other types of diabetes, and then go over how we screen and how we diagnose CFRD, how we manage it, and I'm just going to spend a little bit of time talking about diabetes technologies that are available. So CFRD is the most common secondary complication in people who have cystic fibrosis. So this graph here shows on the y-axis the percentage of people with CF who have CF-related diabetes across all age groups. And you can see as of the age of 10, the prevalence increase starts increasing. So it's about 20%. And then in adults, it's higher, and it's about 1 in 2 adults with CF will have diabetes. And those who have severe genotypes, it's actually greater than 80%. And why is that important? We know that people who have CFRD have lower lung function than those who do not have CFRD. So this graph shows FEV1 predicted on the y-axis across all age groups. Green is CF without diabetes, and the blue is CF with diabetes. And you can see that across all age groups, the lung function is lower. And similarly, when we look at the weight, we know that the weight is lower in those who have diabetes versus those who do not have diabetes, also across all age groups. And we also know that pulmonary exacerbations are more frequent in those who have diabetes in red compared to those who do not have diabetes in green. And the blue is pre-diabetes, so between normal and diabetes. And this is across different age groups. You can see that the rate of having an exacerbation requiring IV antibiotic is higher among those with diabetes. So how does hyperglycemia affect people with CF, and why does it cause these adverse effects? So we know that high blood sugar, hyperglycemia, can induce structural changes in the lungs, like bronchiectasis or mucus plugging, and that has been shown in CT scans that were done in people who have diabetes versus those who do not have it. Also, high glucose in the airways can promote the growth of bacteria and can weaken the local lung defense against infections. Generalized hyperglycemia can weaken the immune system response to infection. And also insulin is an anabolic hormone. So when you have insulin deficiency and high blood sugar, that means you cannot use the nutrients appropriately for energy, and that will result in fat tissue and weight loss, which is not favorable in patients who have cystic fibrosis. We do know that insulin treatment improved these adverse outcomes. I tried to summarize most of the available literature on insulin treatment in this one slide. I just wanted to show that there are multiple studies that were done and looked at this question and found that with insulin treatment, there is improvement in lung function, improvement in nutritional status, improvement in glucose control, decrease in exacerbation rates, and in mortality. That is why it is important to diagnose and treat diabetes and CF early on. So what is CFRD and how is it different from the other forms of diabetes like type 1 and type 2 diabetes? So this is a picture showing the human pancreas, the small organ here that is comprised of an exocrine part, which is usually affected in most people who have CF, causing what we call pancreatic insufficiency. So the exocrine part is the part that is responsible for making the digestive enzymes that help us digest food appropriately. And there is an endocrine part in the pancreas. The endocrine part is what we call pancreatic islets. So islets of cells. And one type of these cells is called the beta cell. This is where the insulin is produced and secreted. And whenever we eat, and also in the basal state when we're not eating, to help us use the food that we're eating for energy. So in CFRD, there is partial loss or dysfunction of these islets that leads to deficiency, but not complete absence of insulin secretion. And this is mainly because of the inflammation and fibrosis that is surrounding these islets because of cystic fibrosis. In type 1 diabetes, it is mainly an autoimmune disease, meaning your own immune system attacks your pancreas, causing destruction of these beta cells. And in that case, we have complete insulin deficiency. Type 2 diabetes, there is this genetic predisposition to having dysfunction in these beta cells that lead to relative insulin deficiency, and that will get worse with unhealthy lifestyle, like unhealthy eating and weight gain. So just wanted to show in this slide kind of a comparison between these three types of diabetes. So we can just help to help understand what the differences are. So in CFRD, the onset of diabetes is very gradual and insidious, versus type 1 diabetes is pretty acute and obvious, and the children, when they present, they're very symptomatic. Type 2 diabetes is also very gradual and insidious in onset. In terms of age of onset, CFRD, we see it mostly in young adults. Type 1 diabetes, we see it in younger children and adolescents. Type 2 diabetes, we see it mostly in adults. In terms of insulin secretion, it is decreased in both CFRD and type 2 diabetes, but in type 1 diabetes, it's completely absent. And in terms of insulin action, or how effective the insulin this is usually normal in CFRD and in type 1 diabetes. However, in type 2 diabetes, it's usually, this is decreased. In terms of treatment, so CFRD insulin is the only treatment that is proven to be effective right now. Similarly, type 1 diabetes insulin is the treatment, versus type 2 diabetes. There are some oral medications that can be given to improve the function of the insulin. Diet and healthy lifestyle can also help with that, and some people will need insulin. And I think in terms of diet recommendation, this is the main difference also between the different types of diabetes. So in CFRD, we still, a high caloric diet is still recommended. There are small changes that I will talk about in the coming slides, but that's kind of high caloric, high fat diet is what is still recommended. In type 1 diabetes, we ask patients to monitor their carbohydrate intake, and we want them to have a normal balanced diet to allow for normal growth. Versus type 2 diabetes, we also ask them to monitor their carbohydrates, and we also ask them to monitor their caloric intake because we want to promote weight loss or prevent further weight gain. In terms of complications of diabetes, just want to mention that briefly. So macrovascular complications, meaning heart disease and stroke, we don't really see that much in CFRD, but we do see it in type 1 and type 2 diabetes. In terms of microvascular, which is kidney and eye disease, that can happen in any form of diabetes, whether CF related type 1 or type 2 diabetes. Um, Next, I want to move to discussing how we screen and how we diagnose CFRD. So currently, oral glucose tolerance tests, or OGTT, is the recommended testing. And because the onset is very gradual, insidious, and most people are not symptomatic when they develop diabetes, the CF Foundation has recommended that we start screening as of the age of 10 by doing a glucose tolerance test once yearly. And age 10 is because, as I showed you in an earlier slide, this is when we start seeing the prevalence of diabetes increasing. So the test basically includes fasting for 8 hours before, and then you come to the lab, you get a baseline blood draw to measure the glucose level. And then there's this concentrated sugary solution that has to be ingested within 5 minutes. And then wait around for 2 hours, and then get another blood draw for 2-hour glucose level. It's not, the patient cannot eat during these 2 hours because that will obviously change the results of the test. And I want to also mention that we occasionally see that, especially in people who have CF, that there is low blood sugar sometimes following the test. So we always advise our patients to bring a snack with them so they can eat after the test is done to prevent that. And the test can be coordinated to be done during the CF clinic appointment, but in that case, we want to make sure we have a first morning appointment to avoid fasting for longer than needed, or it can be also arranged to be done at a local lab, and most of the big, large labs will do OGTT testing with orders from the CF physician. I just wanted to include here the normal values. So normal if you're fasting less than 100, and 2 hours less than 140. And I think I get a lot of questions about if there are any other screening methods that we can use, because the glucose tolerance test sometimes is not very pleasant. Some people get nauseous with the glucola or the sugary solution and can't tolerate it. Also, it's kind of a lengthy test. You have to wait around for 2 hours. And unfortunately, we don't have an ideal test. So some people ask if we can get just a fasting glucose level. And unfortunately, it's not enough, because it can be normal for years before developing diabetes, where the fasting is normal, but during the day the numbers are high. So it only helps us if it's high, if it's elevated. Similarly, the random glucose level does not always capture the high blood sugar. So it only helps us if it's elevated. Hemoglobin A1C, this is a test that people with diabetes are familiar with. This is an average of the blood sugars over the last 3 months. And this test can be falsely low in people who have cystic fibrosis. So again, only helpful if it's elevated. And then the last one I want to mention is continuous glucose monitor, which is a newer diabetes technology device that is applied to the skin and provide real-time glucose monitoring at home. I'm going to talk about it a little bit more in the next few slides, but this is a very sensitive device, can detect hyperglycemia very well, but it's an expensive device. It's not widely available just for screening, and currently still not recommended to use for screening. So currently we still rely on the glucose tolerance test, and those are the CF Foundation guidelines on how to diagnose CFRD. So I talked a little bit about the healthy outpatient. We do glucose tolerance tests, and then those are the kind of numbers that we use for diagnosis. You can rely on the A1C only if it's elevated, or random glucose only if it's elevated. They also recommend that for people who are on continuous feeds to measure the glucose level immediately, in the mid or immediately post feeding. And if the number is over 200, then that's consistent with diabetes. It's also recommended that during acute illnesses, so if the patient is getting admitted for treatment of an exacerbation, to measure the glucose levels within the first 2 days. And if there is high blood sugar, to continue checking. If it persists after 48 hours, then that means this is consistent with a diagnosis of diabetes. And just wanted to include here data from the CF registry showing the glucose screening rates in general in the US. And this is OGTT screening, 10 to 17 years of age. The screening rate is about 66%. And in individual older than 18 years, about 36%. There's a high rate of doing random glucose measurements, but again, as I mentioned, it's not very reliable in ruling out CF-related diabetes. So how do we manage pre-diabetes and diabetes in CF? So if the glucose test comes back abnormal, where it's not in the diabetes range yet, but it's not normal. So fasting between 100 and 125 and 2 hours between 140 and 199. So that means that there's no diabetes, but there is higher risk for developing diabetes. So we usually refer to see the endocrinologist, and we spend a visit discussing this CFRD, what it means, and how it's treated. And we teach the family how to use a glucometer. We give them a glucometer to measure blood sugars at home to get a better idea of what the glucoses are at home on a day-to-day basis. We usually ask them to check about once or twice weekly. And we give them parameters, tell them if your numbers are below these cutoffs, then come back and see us in 6 months just to see how things are. At this stage, there is treatment is not indicated, only monitoring. But what if the test shows diabetes, where fasting is greater than 126 or 2 hours greater or equal to 200? And in that case, insulin treatment is indicated. And we usually start with once daily injection of a long-acting insulin if it's mild, and sometimes we have to do short-acting insulin as well, as multiple injection with every meal to cover the carbohydrates that are eaten. So it's either long-acting alone or long-acting and short-acting insulin. So that's, if it's long and short-acting, that could be 4 to 5 injections a day. And I included a picture here of an insulin pen. I just want to mention that it's a subcutaneous injection, so very short and thin needle that goes right under the skin, and mostly not painful. And it's injected in the stomach, could be in the arms or the legs. And we also asked if we're starting this insulin, then we have to check the blood sugars more often at home, anywhere from twice daily to 4 to 5 times daily. And we also, this is the glucometer that we provide. This is kind of showing how the finger poke is done. Other things that we discuss is regular exercise is very important. It helps the insulin work better. And that applies not just for CFRD, also apply for pre-diabetes. It also applies to all people with CF. As I mentioned before, high calorie diet is still recommended. The things that we discuss is mainly to minimize simple concentrated sugars, so like sodas, juices, and other sugary beverages. And always try to consume carbohydrates with protein and fats. That helps slow down the absorption of the carbohydrate and prevent an acute spike in the blood sugar. We also advise to try to eat on a regular schedule. So 3 meals, 2 or 3 snacks in between, to help kind of check blood sugars on more regular schedule and be more effective with giving the insulin injections. And we also want to encourage that the pancreatic enzymes are taken regularly with meals and all snacks, because it's been shown that pancreatic enzymes also help prevent acute spikes in the blood sugars. Also, people who have CFRD will need to come and see the endocrinologist every 3 months to kind of discuss their management, monitor their diabetes control, and screen for other issues that can come up. Just want to talk a little bit about the available diabetes technologies that we use more commonly in people who have type 1 diabetes, but we are starting to use them more in people who have CF because they can be very helpful in kind of lowering the burden of checking blood sugars and giving insulin. So continuous glucose monitor, this is a picture of one of the CGMs that are available. There is actually, you can't see it here, but there's a catheter, a sensor that is placed in the subcutaneous tissue and measure the glucose continuously in the interstitial fluids. And it's connected to this transmitter that transmits the data to whether a receiver or a smartphone. So it's placed there, and you can continuously see the glucose number on your device. That replaces finger pokes, so there is no need to do finger pokes. Some devices still require calibration, but the newest devices we have now do not require calibration, so you only need to do a finger poke if the number doesn't make sense on the continuous glucose monitor. And some devices, you have to change them every 10 days, and some can last up to 14 days. A lot of people, I hear a lot of positive feedback. People like these devices. They find them very convenient, and they also provide way more data than what we can get with 4 or 5 finger pokes a day. We can see what's happening continuously. We can dose the insulin better based on more accurate data that this device provides. Insulin pumps is also a very helpful technology. So I'm including a picture here. So this is the pump. It has a cartridge that contains insulin in it, and then delivers insulin via this tube, and there is a catheter that is placed right under the skin. This is what we call a pump site. So the insulin is delivered through this pump. You program all the doses in the pump. When you want to eat, you enter the amount of carbs and the blood sugar number in the pump. The pump will calculate how much insulin needs to be given, and it will deliver it. So that replaces insulin injections, and it's the site has to be changed every 3 days. So instead of doing 4 or 5 injections a day, you can use the pump and change the site once every 3 days. This is especially helpful in someone who snacks a lot. So instead of having to do an insulin injection for every single snack, you can just put the amount in the pump and have the insulin delivered without having to think about, oh, do I need an insulin injection now? Should I eat the snack or not? Or should I do an injection or not? So it's definitely a very helpful tool. It still requires some work and diligence about, knowing what the blood sugar is, making sure the site is working properly. But in someone who's interested, it can be a very helpful tool. And the last technology I want to talk about is the hybrid closed loop system. So that is the latest in the world of diabetes technology. So it basically has an insulin pump, a continuous glucose monitor, and there's an algorithm that takes the data from both the pump and the CGM and adjusts the insulin delivery automatically. So because it uses an algorithm, it can provide better control of the blood sugar, and it can also prevent low blood sugar from happening. Like, for example, if the CGM is saying the blood sugar is going low, the insulin pump will suspend the delivery of insulin until the blood sugar comes up. So it's very helpful in preventing low blood sugar and controlling the diabetes better. It's used way more in people with type 1 diabetes, but we're starting to use it in few people who have cystic fibrosis. And so far, the feedback I hear is very positive. This is the last slide. I would like to summarize the important points. So I want to mention that CFRD is common in people who have CF, and it has implication for the lung disease. Early diagnosis and treatment can help prevent the adverse outcomes of CFRD. Currently, glucose tolerance test is the recommended screening method, and it should start at age 10, done annually. Insulin is currently the only recommended treatment for CFRD. Diabetes technologies help lower the burden and manage the diabetes more effectively. And finally, I want to just mention that we still don't know about the effect of Trikafta and highly effective modulators on diabetes, but I know there are some ongoing studies that are looking at that, and we will know more in the next few years. And with that, I'm done, can take any questions that you have.
Great, thank you. It looks like we do have two. One is, does a low pancreatic function score at age 1 or 2 indicate a higher risk of early onset CFRD?
Sorry, can you repeat that? A lower?
Sure. Does a low pancreatic function score at age 1 or 2 indicate a higher risk of early onset CFRD?
So we do know that people who are pancreatic insufficient, yes, are at high risk for diabetes. We rarely see it in people who are pancreatic sufficient. So yes, it's mostly in pancreatic insufficiency. I don't know if there are specific studies looking at the score and the correlation with diabetes, but we know that insufficiency by itself and having a more severe genotype is associated with higher risk of developing diabetes.
And the other question is, do we know what % of CF patients also have diabetes?
What % of CF patients?
Mm-hmm.
Yeah, so it's different per age. We start seeing as of the age of 10. So in adolescents, it's about 20%. And in adults, it's somewhere between 40 to 50%. But if you have a severe genotype, it's about 80% in adults.
Wow, thank you so much, Dr. Mirjani. That was so wonderful. We appreciate you taking the time to be here with us today.
Yeah, sure.
Busy.
Thank you for having me.
Next up, we have Catherine Sebring. She is a colleague of mine, and she is going to come on and talk about our Compass program. Hi, Katie. Welcome. Thanks.
Hi, thank you so much. Let me go ahead and share my screen. So thank you so much for having me. My name is Katie. I'm a case manager with CF Foundation Compass, and I have been with the foundation for a little over 3 years now. So for anyone who may not be too familiar with Compass, so we are a team of case managers who help with issues like insurance, financial, legal, or other complex issues. I can go into more detail with all of those categories. Also, so complex issues would be basically anything else. So that can be transportation, food, scholarships, and many more. So Ozzy Cater leads the Compass team. We have 2 operational managers, Hodgin Moon and Aaron Stocks. Aaron and Yamini are our 2 senior specialists. We have 12 case managers who help directly with the CF community, address their issues and work one-on-one with them. And then also Aaron and Martha are our 2 bilingual case managers. So they are fluent in both English and Spanish. And then we also have a language line available for us to use that assists with more than 200 languages. So Compass eligibility, our services are available to anyone with CF, including those who are pre and post transplant. Also their families and caregivers, providers. Compass is open to anyone. So there's no income criteria, there's no insurance criteria, no care center criteria. Our services are free and confidential. And it is important to note that Compass does not provide direct financial assistance, but instead we help connect the CF community to various resources who may be able to help directly with financial issues. So contacting Compass, you can call us at 844-COMPASS. We're available Monday through Thursday, 9 a.m. until 7 p.m. Eastern. And then on Fridays, 9 a.m. until 3 p.m. Eastern. You can also email us at compass@cff.org. You can also submit an online service request form at cff.org. You would just go to our website, click the Assistant Services tab, and then click on Connect with Compass. Okay, so a little bit more of a deep dive into our Compass services. So we can help people get new insurance, or if they are switching plans, we can help people understand insurance benefits and tackling complex coverage issues. We can find resources to help pay for things like medications, therapies, and really just other costs associated with CF. We know it's an expensive disease, so we try to connect people to as many resources as possible. Getting legal information on topics like disability, government benefits, employment, or school accommodations, and dealing with other concerns related to life with CF. So just a couple case examples. So family lost insurance due to reduced hours. So with this, it was because of COVID-19. So the case manager helped compare all available insurance options. This included COBRA and health insurance marketplace options. So again, getting that individual case management to help get them set up with a new plan for the whole family. Another one, telehealth visits not being covered. So luckily we don't see too many coverage issues come with this, but anything is possible. So we did have a case come in. The employer was not covering telehealth. So the case manager worked closely with the family and helped self-advocate to the employer to get it covered. And then, so CF families needing help affording food, help applying for college scholarships. So 2020 was a difficult year for everyone. And because of the pandemic, there was an increased number of requests that we did see for these two areas. So we connected many people to food resources and then scholarship resources. So COVID-19, Compass has handled, we continue to, over 1,000 COVID-19 inquiries. So in the beginning, when everything kind of started to happen with it, back in March of last year, we started to see a lot of calls come in. It started with questions on fear of supply shortages, along with risk of exposure in public settings. And then it started to move to calls associated with work accommodations and legal protections. And then about middle of the year, around June, we started to see a lot of financial hardship. So we got a lot of calls with people, really just being heavily impacted by COVID-19 if they lost their jobs and they needed help with rent, utility assistance, food. Again, trying really hard to connect them to as many resources as possible, given each person's situation. And then a few telehealth access and coverage questions. Again, not too many issues in that area, but we did get some calls where we helped helped them check to make sure that that benefit was covered with the insurance. And then if it wasn't, and kind of going from there and seeing what we could do with insurance. And then as people, families, kids started going back to school, we started getting a lot of school accommodations and legal protection inquiries. And then today, I would say for the last, ever since the vaccine has come out, so, in the last month or so, we're getting a lot of calls with just general questions on the vaccine. So in addition to COVID-19, we also help with natural disasters. So we have a team of case managers who are available during times of disasters to help with issues like getting damaged equipment or medications replaced, locating local relief programs, locating shelters, things like that. Again, depending on their needs if they've been impacted by a disaster. So while Compass case managers identify and address the issues with the CF community on an individual level, the public policy team provides their expertise on policy barriers at a systems level. So we always encourage people with CF and their families to advocate for themselves by engaging policymakers in their local community. So these are just a few ways to get involved with that, and that's also found on cff.org. And then just a few other community support resources besides Compass. So CF Peer Connect, that's a great program. It's a one-on-one peer support. You get connected with someone who has been through a similar situation. So depending on what kind of support you or someone you know might be needing, they get matched up with someone who can relate. Community conferences, so there's a lot of virtual events to connect, learn, and share with others in the CF community. A few examples of these are BreatheCon, FamilyCon, ResearchCon. You can find these on our website as well under virtual events. And then CFF Cares, casual, in-person, and virtual events for social support with fellow community members. So if you have questions, just reach out to us. We most likely can help you with, whatever issues you're going through. So if you're not too sure, just give us a call and we will do our best to help you out. And again, there's a lot of different categories that we assist in. So just reach out and we're always happy to help. And that's it. Thank you so much. I appreciate your time.
Thanks, Katie. I don't see any questions at the moment in the chat, but I just want to thank you. I know what an important resource this is, and I am always blown away by everything you guys do. My kind of go-to is if I hear about any issue, I'm just like, call Compass.
Right.
It's hard to even list the amount of things you guys do or can help with. So it's really just like, even if you think that maybe this isn't something that Compass covers, it's worth calling and finding out because they can probably find somebody who can help you.
Exactly. Yeah. Yeah.
We're
Thank
just
you
so
so much
appreciative.
for your kind words. I appreciate it.
Yeah. Thanks, Katie.
Thank you.
I'm going to take just a moment now, guys, and I want to talk to you about great strides this year. So I know that 2020 was strange, right? Can we say that, to say the least? And we had to quickly pivot to this virtual world and this virtual celebration. And we were really blown away by the way our community stepped up and they kept fighting for that cure. You sent in videos, you made Facebook fundraisers, you did whatever was necessary. And it was an honor to go through 2020 with you and to just show how resilient our community is. But I think the magic of Great Strides has always been seeing everyone who shows up with the same goal, fighting the same fight, and celebrating how far we've come. And we're still not at a place where we can have the walk as we know it, but we found a really great way to keep that community spirit. And that's why we're so excited that Great Strides is becoming Great Rides this year. We're hosting a series of drive-in movies and one car parade. And it's going to be a really safe way for us to be together, see the power in our numbers, and really celebrate. And so Great Rides kicks off on May 1st in Gig Harbor. It'll be May 8th in Spokane, May 22nd in Seattle at Marymoore Park, June 5th in Poulsbo, and then our car parade will be in Tulalip on July 11th. So you just want to make sure your team is registered for Great Strides to find out how to secure your spot. And then, sign up. Get ready for the drive-in, grab your snacks, your family, your friends, and spend the evening with us. We think it's going to be really, really special. So with that, we are just going to take a little break. I'm going to give you guys an opportunity to stretch your legs, grab some water, and we will be back at 11:30 for our next presenter. All right, that was quick, but we're back and we're ready. Now we have two really wonderful presenters joining us today to speak on CF and COVID. We have Dr. Chavez. She is a pediatric pulmonologist in Spokane, Washington. Her inspiration to specialize in pediatric pulmonology came during her first North American Cystic Fibrosis Conference, where she felt the energy toward a common goal of finding a cure and wanting to be a part of reaching that goal. She trained in Albuquerque, New Mexico and Little Rock, Arkansas, and worked in Central Texas prior to moving north to Spokane, Washington, for the sake of adventure. Her passion is in building relationships with patients, families, and care team members to help each reach their full potential. In her free time, she enjoys reading, doing science experiments with her sons, and more recently, skiing on the greens. We also have Demi Schneidmiller. Demi grew up in a small town in Oregon and got her BSN at University of Portland. Her first job was working at 7 North at Sacred Heart in Spokane, and that's where she really fell in love with the CF work. She took care of many adult CF patients and each time learned so much from them. She loved the hospital, but knew it just wasn't where she wanted to be forever. So when the opportunity came up to join the CF team in the clinic, she knew it was just meant to be. She loves her CF patients, families, and the CF team. Outside of work, she enjoys spending time with her husband, 2-year-old little girl, and spending as much time outside as possible. Thanks so much for joining us. You are both muted if you want to unmute.
Perfect. Can you hear me
Go.
okay?
Yep, great.
Awesome. All right. Hey guys, so I am going to share my screen and we're gonna do our little PowerPoint. Hopefully you can see that okay and everything. So today we're going to talk about CF and COVID. And I know it's kind of something everybody has heard a lot about, but it's also something that's really important to talk about as well. So kind of an overview, I'm going to start off and I'm going to just kind of go over a little bit about what the pandemic has been like for care with CF and our community, and then the efforts that the foundation has been doing to help during the pandemic. And then Dr. Chavez is just going to do a brief history of the COVID pandemic, and then what we know about CF and COVID, and then what we think the future looks like going forward and for CF care. So to start with, so how has CF care changed since COVID? And this is just something that some of it's personal to what our care center has experienced as far as care during the face of a pandemic. As a lot of you probably all know, we have gone to virtual appointments and lots of them. And I think that has been a great thing. It's a wonderful experience to be able to see people in their homes. And I know a lot of the providers have got to see pets and siblings and things like that, things we wouldn't normally see. Another thing that has changed is we got to do a lot of extra testing. So lots of COVID testing in order to do, as we head back into the clinic, to be able to do PFTs. And then the other thing, as far as if you aren't able to do a PFT in clinic, is the home spirometer. Something, as you can see right here, this is actually what it looks like when it comes to your house. And so being able to actually do lung function testing at home has been really helpful in being able to get the best care over a virtual appointment. And then the other thing is spacing out in-person appointments. Our clinic is currently heading back into using in-person appointments. But we also know it's really important to consider the safety of our patients. So we always were conscious of infection transmission and things like that, but now it's even more so. So it's like one provider a day is seeing patients in clinic. We try to space out where we do an in-person and a virtual so that patients aren't all together coming in at once. And then another really cool thing that we created was dedicated team visits. So for those virtual appointments, you're usually only seeing the provider, but we all know that CF is a multidisciplinary team. And that's the cool thing about it, is that we get to see a dietitian, a social worker, the RT. And so we realized we were missing that. And so being able to create these specialty team visits where it's either virtual or in person, where you can actually just meet with the team, go over things that the provider had said, talk about other concerns, and it actually gives you a little bit more time instead of those like extended 3-hour-long appointments you have while in clinic. There's lots of phone check-ins, another cool thing is research consenting online. So we were able to have our research coordinator send out registry consents and then be able to do a virtual appointment or a phone call and actually consent that way. So we were able to continue research as well. We also figured out how to do, at least for the adults, doing the mental health screen via an electronic medical record, which has been really cool to be able to actually just send it out, do it that way even before the appointment. And then we also helped connect families and patients to specialties during COVID. So like assistance like food and bills and things like that. So another thing is, how have we become innovative? I mean, in CF, it's something that we are always really good at, about trying to figure out how we can provide the best care to our CF patients. Some of the ways that our clinic, and then I've also seen throughout the nation that people have been innovated, is creating, like I said, those team visits. We also, since people weren't coming into clinic and we needed those sputum samples and things like that, we created sputum care packages, where we actually sent out sputum cups if you were able to provide a sample. It came with the orders, instructions, and even a little treat, because one of my patients said that getting a sputum cup in the mail is not a care package. So we updated that one. We also created email blasts for our patients. One of the big things with COVID is there's so much information out there, and it's hard to really sift through everything that's important. So being able to make a concise email with like the high points of what you should be paying attention to, and then easy links of where you can find out information to get COVID tested in your area, where the most credible sources are to, if you have questions in regards to COVID and things like that. So that was something that we tried to do at least on a bi-weekly basis, especially early on during the pandemic. Then the other thing is usually when you would come to clinic, you would get a box or like paperwork and everything like that. But since people weren't coming, we sent out care packages with supplements, educational materials, encouragement. Those are just a couple of the things. We also did virtual learning days, and then the first virtual NACFCs. So just lots of really cool ways to help kind of continue care in the face of a pandemic. And then as some of the, as Compass had talked about early on, the foundation also really created good ways to help patients and families during the pandemic. They've really focused on mental health and well-being. There's actually a recorded session from earlier this week on helping with that. They also helped with coordinated efforts to help understand how CF or how COVID affects people with CF. They are really continuing their research efforts, advocacy for patients to get the vaccine, get the extended leave they need, things like that. And then just continued updates with kind of like how we did with information in a easy to find spot on their webpage that not only helps with helps the care teams, but also helps families and patients understand what is going on and what you should really look at, and hopefully help answer some of those questions that you have as far as the pandemic and COVID. So those are kind of just how the foundation helped. And then now I'm going to turn it over to Dr. Chavez, who is going to talk a little bit about just CF and what we know about how it affects, or how COVID affects CF.
Yeah, thank you, Demi. So we're going to switch gears a little bit and kind of reminisce on the last year. I know that all of us have experienced similar experiences, but also very different experiences. So as I go through these things, maybe you could reflect on how COVID has played out for you and your family. So before we even knew that COVID was in existence, a small group of people developed pneumonia in the city of Wuhan in Hubei province in China. That was December of 2019, as far as we can tell. Just a few weeks later, after doing a bronchoscopy on one of those patients, they found a novel member of the coronavirus. And then in January 21st of last year, the CDC confirmed the first case of coronavirus here in the state of Washington. It was the first case in the whole United States. About 3 weeks after that, the World Health Organization coined the name COVID-19, which stands for Coronavirus Disease of 2019, because we know that it started in 2019. Little did we know that COVID-19 would become, our everyday word for ever, I think now. In March 11, and I kind of remember those days. I didn't think that COVID-19 was going to become a huge problem in the United States, and boy, was I naive. But on March 11th, the WHO declared that COVID-19 was a worldwide pandemic. I clearly remember 2 days after that, on Friday, March the 13th, when the Washington state governor declared a state of emergency, closed down schools, closed down all businesses. It finally hit home. Okay, this is something real that is going to change our lives, but I wasn't sure yet how much it was going to impact our lives. So still in March, Washington State issued its first stay-at-home order. We all of a sudden had to be creative, and I think there was a lot of also overcoming our fears and just going on with providing care for our patients in the CF clinic at that point. On the family side, I think when that stay-at-home order was issued, the fear born out of love for our family members and especially for those that had to continue to go out and work, it was a real thing, and that is when collectively as a community we came together. And I will always look back on that period of time as one that showed the resilience and the care that the CF community provides. Later in March, the CARES Act came into existence and provided some financial support for families. Around that time, the CF Foundation had to decide whether to continue the in-person or cancel in-person, conferences. So they planned the first ever virtual North American Cystic Fibrosis Conference, which occurred in October, and it was a fantastic conference. A few months after that, in the midst of the third wave of the pandemic, the vaccines, news started coming in that the vaccines were FDA approved. In December, we had both the Pfizer and the Moderna vaccines. And then in February of this year, the Johnson & Johnson. Can you forward slide, please? So how has COVID affected people with cystic fibrosis? I have a bit of a comparison here from just the general population based on the Johns Hopkins database. There have been 30.9 million cases as of earlier this week of people who have been reported to contract coronavirus in the whole United States. That's about 10% of the population. Out of that 30.9 million cases, there's been 556,000 deaths, which is about 1.8%. According to the CF registry that has about 30,000 registrants in it of people with cystic fibrosis, there have been a reported 1,357 cases as of yesterday, which is about 4.5% of the 30,000 registrants in the registry. This translates to less than that 10% of the population, which is very good news. even one death of a person with CF because of COVID is too much. We have had 14, and our hearts go out to those that have lost a loved one. What we know about these 14 deaths is that more than half of them were people who had received a lung transplant. So they already had immunosuppression. The other risk factor that we know of is when pulmonary function tests are low, indicating advanced lung disease. So an FEV1 of less than 40% is also a risk factor for either hospitalization or death from cystic fibrosis. I mean, from COVID-19 in the setting of CF. So why do we have this good discrepancy between the population of people in the CF registry, which, by the way, has also been shown in the European version of the CF registry called COVID CF Project in Europe, where only about 1% of those that have contracted the disease have resulted in death also. There are several theories, but I think the one that makes the most sense is that people with cystic fibrosis are experts at preventing spread or contracting viral illnesses to begin with. You know, ever since children grow up with CF, we kind of hammer into their little routines, washing hands and, you know, sneezing or coughing into your elbow, those kinds of things. By the time that a person with CF has reached adulthood, they have 20 plus years of experience in infection control prevention. So that has probably played a big role in people with CF not having as high of an incidence of contracting COVID. However, there's also some suggestion that the virus SARS-CoV-2 attacks cells that have CFTR malfunction. CFTR is the little channel that is affected in sodium balance in all of the cells of people with CF. It seems that having a malfunction in that CFTR channel makes a difference in how SARS can attack those cells. So the CF Foundation has been supporting research into this, and there is an ongoing study out of Stanford. So hopefully we will have more information on that. And then other theories are that maybe hypertonic saline and Dornase and, you know, keeping up with vitamin D levels all make a difference as well. So all of those kinds of questions hopefully will be answered and will be more clear in the upcoming year. Next slide, please. So here's the most exciting part, in my opinion. The vaccines are you've probably heard this before, but they are what we needed in order to create that herd immunity so that the COVID virus, the SARS-CoV-2, doesn't continue to spread. So right now we have 3 of them. The Pfizer-BioNTech vaccine is for people 16 and older, and it was FDA approved after doing all of the phase 1, phase 2, and phase 3 trials. In those trials, 8% of the population that was included in those trials had chronic disease. We don't know if it was CF or something else, but we just know that it was chronic disease. The Moderna vaccine is for ages 18 and older, and those trials included 5% of people who had chronic disease. And then the Johnson & Johnson, more recent one, is also for 18 and older, and that one we do know that included 4 people with cystic fibrosis. As of yesterday, again, the registry data show that 2,144 people with CF in the registry have received a vaccine, which is very exciting and excellent news, and we hope that that number will continue to increase. The important thing, because I know the rollout for the vaccines has been confusing at best and very frustrating for most people in trying to see where they can get it and when they can get it. But the important thing to know about all three of these vaccines, regardless of which one is available, is that they have shown to decrease the risk of death and hospitalization by over 99%. That means that if you have the vaccine and you contract the virus, there's a very tiny chance of resulting in hospitalization or death. So it's definitely worthwhile. So what about children? Because again, we love and care for children that have CF, and we would like to protect them as well. Yesterday, the Pfizer uh, makers, the ones that make that vaccine, requested that the FDA allow vaccination for ages 12 and over based on really good results from the studies that they did on that age group. And then there's also ongoing studies for all three vaccines for the younger age groups. The Moderna one is recruiting for children ages 6 months and over. So I think my hope is that this summer, those ages 12 and over will be able to get the vaccine, and the younger age groups, hopefully by early 2022. And yes, in the left or right lower corner, that's me giving a thumbs up. I was giddy with excitement when I was able to get my vaccine, and it just felt like we were making history. So next slide. So yeah, I don't have a crystal ball, but I do have hopes. I do have dreams. I hope that the good things that have come out of this COVID pandemic will remain. And some of those are listed here. The home spirometry program, I think, is excellent because it provides like an extra vital sign. I remember when we could check our oxygen at home, and that was very exciting because then we knew when somebody's oxygen level was dropping. The home spirometry is a similar vital sign where we can use it as part of our decision making for when to start antibiotics, for knowing if these antibiotics are helping. So it is an excellent tool that has come from this COVID pandemic. Virtual visits, like other people have mentioned, just kind of ease care and the burden of coming into clinic as often. I think my hope is that they will be a good adjunctive way of providing care with a hybrid, using the school words, a hybrid care model with some visits in person, some virtually. And then the home throat culture collection has also provided a way of collecting cultures when in situations when we couldn't have otherwise. As far as vaccines, I don't know if we're going to have booster vaccines every year like we do with the influenza vaccines, or if it's going to be a one-time vaccine. I don't think anybody knows. So far, we know that the Johnson & Johnson vaccine seems to cover the new strains of the SARS virus relatively well. So we're optimistic that hopefully, it'll be a one-time set of shots, and then you won't need any further ones. But there will be more to come on that. So yeah, if you can change the slide, please. So this is our care team here in Spokane. We had to say goodbye to one of our physicians, and this is the picture of our toast to her. So we were holding some non-alcoholic drinks when we were celebrating her kind of retirement. But again, being part of this team in clinic, but the broader team that is made up of patients' families, of the Cystic Fibrosis Foundation, it has really pointed out how creative, courageous, and determined people that are impacted by CF are. And I'm just very proud to be a part of it. And it will take any questions if anybody had any.
Thank you so much. It doesn't look like there's any questions at this time. But I just want to say thanks so much to Providence Spokane. You know, you guys really are on the other side of the state from us. So we are so looking forward to when we can come and visit you guys again in person. And I also just want to say that you guys put on an incredible education day. I know you did a virtual one, and it was one of the inspirations for us when we were putting this together. We saw your lineup. Trish in our office was a part of it, and she just couldn't say enough good things. She was raving about you guys. So thank you for inspiring us, you know, and also being a part of this and helping us put it all together. It's really great.
Thank you. Yeah, thank you for having us.
Yes.
All right, next we're going to go to a CF research update. And that's with Dr. Goss. Dr. Goss is a professor of medicine and pediatrics at the University of Washington. He is the co-executive director of the CF Therapeutics Development Network Coordinating Center, housed at Seattle Children's Research Institute and Seattle Children's Hospital. He has been intimately involved with CF clinical trials since 1999, including work that addressed the role of azithromycin used in CF, inhaled tobramycin in CF, and the impact of CFTR modulators on patients with CF. He is an epidemiologist and is the co-chair of the CF Foundation's Patient Registry Committee. He is also the associate director of the Adult CF Clinic at the University of Washington with over 20 years of experience in clinical CF. Dr. Goss, whenever you are ready.
Well, I want to thank you for inviting me on this glorious day in Seattle. And I'll try to, let me just start this presentation. But it's really great to be here, and it's great to be able to do things, I think, in virtually. Although I do like meeting all of you in person, so I hope that we're back to that at some point in the future. I think we probably will be. But again, it's my pleasure. I'm giving this talk from my office at the university, looking out on Lake Union, and a glorious day this morning. I wanted to talk about sort of a little bit of the improvements to date, and a little bit of how we got here, and then I'll touch on some of the future, and just I think some of the stuff many people would know, but at the same time, it's I think is important to know what has transpired in CF in the last year and a half or 2 years. So this first slide really sort of delineates what's happened in survival in CF. And survival is always looking backward metric, meaning we tried to see what happened in the past. And I started in the CF clinic in 1999. And what the CF Foundation's registry has been able to do is really track survival over time. And right now, last year, the new data will be up soon, but the 2018 data showed the median survival was 47.4 years. And again, that's in the past. And they try to do with these running 5-year intervals just to sort of smooth out the ups and downs, but it's been this really dramatic change in my time in the CF clinic. And again, as a lung doctor, I haven't seen any other changes in other diseases I routinely take care of compared to CF, and the change has been so dramatic. And it's had a big effect on the CF population. I think this graph shows what's changed so much. I'm an adult pulmonologist, and when I started in CF clinic, I think we had just over 100 patients, and now we have over 350. And what's happened in CF, this graph shows the number of individuals with CF divided by whether they're adults or pediatrics. And what you see is that the pediatric population has been relatively stable over time. It's probably expanded a little bit with better early diagnosis with newborn screening. And that all started in 2009 nationwide, although some states were screening much earlier. But then this sort of continued growth of the adult population. So now it's well over half the population. And this has happened all over Europe and any of the developed countries where CF is tracked in registries. And this is really a remarkable sort of point of success. And it's so stark that we actually have a number of patients who are in their 70s in our clinic, which if you'd asked me when I started this business, if that would ever come true, I would have said no. That it just seems like it's too bold a statement that could actually happen. But how do we get there? And I think it really, from my perspective, it's centered on these two characters. The person on the left is Bob Bell, the past president of the CF Foundation. And the person on the right is Bonnie Ramsey, professor of pediatrics here at the University of Washington and Seattle Children's Hospital. And they had, the CF Foundation put a lot of money into understanding basic science, but they really had to sort of bridge this gap from understanding CF as a disease to actually turning around and getting therapies for it. So they developed the CF Therapeutics Development Network in 1998, and that was run out of Seattle Children's Hospital. And the network now has over 90 sites and really tasked with conducting clinical trials to making sure that new ideas, new therapies get studied, and when beneficial, move toward patients in a much faster way. And I think this really transpired for CF in a way that very few diseases have seen. And just to give you a sense of how this network began with only 7 sites and now with over 90. But more importantly, now the CF Foundation really has a network of networks. And this is just to give you a feeling for what it's like. These are the CF, the blue dots on this giant map of the United States are the CF centers all across the United States. And the size of the dot is a little based on the sort of population size and how large they are. So these are the CF clinical centers. And these blue dots are the Therapeutics Development Network. So it's really extensive network of sites all over the country trained to do clinical research and run clinical trials that can actually allow medications to be evaluated and then approved by the FDA. They've also moved to something called the Success with Therapies Consortium. And these are the yellow flags. And they're quite extraordinary. These are centers that are here to enhance our ability to help patients adhere to therapies and really understand how to best achieve reducing barriers to therapies and also enhancing that they can be done. The next big network that came to be is the Non-Tuberculous Mycobacterium Consortium. And we're part of that also here at the University of Washington. And this is trying to get a group of experts together that can actually start to create the groundwork to study new therapies for non-tuberculous mycobacterium infections in CF. And 2 more networks have actually begun. The CF Learning Network, which is a real-world research and advocating quality improvement and adding that to our care models. And again, a very successful model of how to improve the care of CF patients. And the most recent consortium is the Lung Transplant Consortium, trying to improve the outcomes of patients who do need lung transplant who have CF. Now, what has this all led to? And I think I like, this is a graph that Dave Nichols at Seattle Children's put together, and I've sort of amended, which really says some of the improvements and advances in therapies, and going all the way back to the 30s and 40s. So we had pancreatic enzymes really starting in the late 40s and early 50s, and actually really sort of understanding that high salt in the sweat was due to CF. And then we added airway clearance and anti-staphylococcal antibiotics in the 50s. And a pseudomonal antibiotics in the late 50s, early 60s, lung transplant in the 1980s, and then started this series of therapies, DNAs or pulmozyme, inhaled tobramycin, oral azithromycin, hypertonic saline, inhaled aztreonam, and then the real breakthrough therapies, ivacaftor, lumacaftor, ivacaftor, tezacaftor, and then elexacaftor, ivacaftor, and tezacaftor. And again, it really links to the survival improvement in CF over time. So it's interesting that each year, an analysis of looking from 2000 to 2010, the mortality decreased by about 1.8% per year in that decade. And again, this sort of survival of median survival of 47.4 years looking backward. So I think it's really, it's really been an extraordinary advance. Now, I do want to sort of reiterate that we don't know what the novel therapies will do. So we've had great advances, and I think it's actually going to be even more stark now that we have a number of these novel therapies. So again, this is now really the era of what I term CFTR modulators, this CFTR protein that's mutated and is modulated by these small molecules and made to work, really addressing the basic defect. And all of our prior therapies merely sort of looked at downstream effects of CF. And ivacaftor was approved in 2012, so we've almost had this drug for 10 years, which is remarkable. And then lumacaftor, ivacaftor in 2015, tezacaftor, ivacaftor in 2018. And I think the most stark change has been elexacaftor, tezacaftor, and ivacaftor in 2019. And really I think it was right about the North American CF meeting in 2019, before the pandemic began, that this drug became available and it rapidly rolled out. And just to show you, to remind you how well these drugs worked, this is a graph from Bonnie Ramsey's paper in the New England Journal, showed the effect of ivacaftor on a patients with a single mutation, the G551D, which is a mutation that patients have the mutated protein on the surface of their cell, but it's a channel that doesn't open well, and the drug turns it and opens it. So this is just the change in lung function right after starting the drug compared to placebo. And it had a really instantaneous, profound effect. And I can say that we had a patient here who was being evaluated for lung transplant, went on this drug, and was no longer, we deferred lung transplant, and we still have deferred lung transplant. They've been on it for 10 years, and we're not having those discussions yet. So really, really stark, almost immediate effect. And I think what it also proved is we had this really cool readout, because we could just measure their sweat chloride. And the sweat chloride in patients who were in this trial dropped by 45 points within basically the first 15 days and stayed down through the whole duration of the trial. And so this was obviously a breakthrough therapy that now has been in use for, again, almost 10 years. And this is really what our new era, which is the elexacaftor, tezacaftor, and ivacaftor, which really improved lung function for Delta F508 homozygous patients. I think the other two therapies had small marginal benefits, but for patients who were already on tezacaftor, ivacaftor, it improved lung function almost 10% by 4 weeks. So people who were already partially treated. And also it was impressive, their sweat chloride decreased by 45 points, which was a normal sweat chloride is under 30, an abnormal is 30 to 60, and a disease diagnostic sweat chloride is 60 or above. So a lot of patients are likely no longer in a disease category. They're in this indeterminate range in CF. And then there's also this profound effect when they looked at patients with just one delta F. And these patients weren't on any modulators before they started this drug. And so they went from placebo to this Trikafta or elexacaftor, tezacaftor, and ivacaftor. And they improved their lung function almost 14%. And it was pretty immediate, again, by day 15. So these effects have been profound, and it decreased the exacerbation rate by 63%. And this was sort of a longer term study, 24 weeks. But since that time, we've really seen this drug roll out, and now it's they had an expansion of its label indication in December, adding more mutations. So anyone in the United States who has a single delta F and a number of other mutations is eligible for this drug. And is now at about, I think it's well over 90% of our patients here at the University of Washington Adult Center. And it's, again, I think we'll hopefully see soon approval for patients ages 6 to 12, which I think the study was impressive. It was already published in the American Journal of Respiratory and Critical Care Medicine. So it's at the FDA, and we wait to see when it gets approval. But what's happened over the last year? It's been a crazy year for all of us. You know, we've been, as people have noted, we've been doing endless telehealth visits. Patients have been really sequestering themselves, trying not to get infected with COVID. But it has really affected care. But this came as, so this drug was rolling out at the same time the pandemic began. And I got this slide from the foundation. I think it's an interesting and instructive slide to think about how the drug is working versus how the pandemic is affecting patients. So this is CF Foundation patient registry data, and these are the number of pulmonary exacerbations per month in patients 12 and older and 11 and younger. So blue is the young children, and red is the older children. And it had been fairly steady through 2019 until the release of the drug Trikafta, at which point the number of exacerbations just sort of started plummeting to the point when in the mid-February, it had already decreased by substantially. It was down to 39% of the patients had actually experienced, of these patients had experienced exacerbation. And then came COVID-19, and where we get more and more isolation and basically a sudden evaporation of viral infections like respiratory syncytial virus and influenza. We've not had a single case of influenza at this hospital for a year. And the exacerbation rate continues to fall and stays low through the whole year. And so somewhere in this last year, there's a profound effect of Trikafta, but there's also an effect from the pandemic. As you see, the small children who are not on Trikafta had a pretty profound drop in exacerbation rate between the before and after the coronavirus pandemic picked up. Something else that's happening is the use of personalized medicine. And this is using either nose cells or rectal cells that they grow up in these things called organoids, which are blobs of cells. And then you actually can then apply CFTR drugs, modulated drugs, to the cells and see what they do. And a number of centers around the country have been testing cells for CF patients. And it's actually one way we've been able to get Trikafta to patients who are not, have mutations that are not on the label. So this is an example of an epithelial cell organoid on the left on this nice little photomicrograph. And then if we activate CFTR, they look like this. They look big and blobby. And that's when you turn on CFTR, that the lumen in the middle gets huge, and that swelling, the amount of swelling actually can help predict whether a patient will respond to drug. This is sort of a lovely picture I got from the folks at the University of Cincinnati, just showing one of these organoids. And these are individual epithelial cells in a ball around an internal lumen. But this technology, it was made a little bit moot because many of the mutations that I had been testing patients for were then added to the label. But they're still ongoing. This process is still ongoing. We still try to sample patients' nose cells. The pandemic really did offer a significant challenge to doing this, and I think it's probably, we're waiting until I think July before we'll be able to submit more cells to Cincinnati. But what we do is we take a small little brush and we put it in your nose and we twist it around and it gathers cells. And then we put it in a cell culture medium, tighten it up and put it in a refrigerated box, a box with some ice. And then we send it FedEx to Dr. Brewington at Cincinnati Children's Hospital and Medical Center. And then he grows these cells out in big sheets and also makes these organoid balls and then tests the different drugs available. And so there's still a lot of hope that for some of these rare mutations that were not included in the label, we can actually be able to get this drug Trikafta or ivacaftor, whichever works, to patients with CF. And again, this effort is still going on. Stanford is doing this for the West Coast, University of Cincinnati and University of Alabama. I think there's one other center. But Again, the pandemic has slowed down their receipt of cells, so that's really challenging, but this is all supported by the CF Foundation. And it's really, I think, a really dramatic and exciting area of where research really blends right in with clinical care. I think there's some other really exciting news that's come out in the last year. And this is, I think, has a lot to do with looking at the future. This is a picture of a ferret. And it turns out that with funding from the CF Foundation, the NIH, scientists at the University of Iowa have made a ferret with CF. And they've made a couple different kinds of CF ferrets. And what's interesting is CF ferrets look a lot like CF patients. They have fairly significant pancreatic disease. And it seems to be a very good model. And they made ferrets with a specific kind of mutation, G551D, that works with ivacaftor. And then they were able to make homozygote ferrets. And then what they were able to show, which is really remarkable, is they gave these CF ferrets, they had pregnant CF ferrets. They were able to give them ivacaftor when the mother was pregnant. The CF ferret had CF, and all the pups were CF, and they were able to give ivacaftor, and that actually prevented the destruction of the pancreas. And it really you start to wonder if you could start giving these medications to mothers if you knew they had CF children. They have a CF a baby in their belly. Could you give these drugs and actually reverse some of the tissue damage that occurs very early in CF? When they took away ivacaftor, the ferrets got CF again. So we do know that ivacaftor is now approved down to age 12, 12 to 24 months. And in these small children, ivacaftor may be rescuing the pancreas of patients who would normally we would assume would have pancreas that doesn't work. So again, these small molecules are really could have a profound effect. We have no idea what introducing these medicines early to children. Do they not get any lung disease? Their pancreas is normal? Can they then go on and live a normal life without needing any of the other CF therapies? Another very interesting piece of data has come out of a study called PROMISE. PROMISE is a large observational study to see the effect of Trikafta or Lexicaftor, ivacaftor, and tezacaftor on adults with CF. Adults, I think there's some adolescents in this population, but they have 490 patients. And what we did is we actually enrolled these patients just before they got Trikafta. And then we looked, this is just a subsample of the patients who are producing sputum. And we looked at whether they actually, what their microbiology did. And this is Pseudomonas. So in orange are the patients who seem to have continued Pseudomonas in their sputum before and after Trikafta. In blue, these patients converted to negative Pseudomonas. And again, they had fairly high levels of Pseudomonas in their sputum. And in gray, these are the few numbers of patients who seem to have new Pseudomonas. But what it showed is that actually up to 3 months after Trikafta, in this figure on the right, almost 20 of 40 patients followed longitudinally didn't seem to culture Pseudomonas. So it's a very interesting time. Maybe the microbiology that we normally think about for CF infections is going to change dramatically. Maybe we're not going to see as much Pseudomonas as we used to. So this is exciting news. It's early. We'll see what happens when they do the next cut of the data. They'll have more patients, and we'll try to figure out, are people indeed losing some of these pathogens that have really caused a lot of challenges for CF care providers and CF patients. Another study I did want to mention, which is this study called Simplify. And this is an unusual study. It tells you how remarkable the CF community is. This is a study that evaluated patients who were newly started on Trikafta to see if they could come off their inhaled hypertonic saline or their inhaled pulmozyme or DNAs. And the sample size is 800 patients. This study began just before the beginning of the pandemic. And despite this, so they have it's two arms of a study. Patients are randomized if they're on hypertonic saline, they can get randomized to removing hypertonic saline, or if they're on pulmozyme, removing pulmozyme. And the idea is to say, is it safe to take away these medicines that they've been on for a long time? Do they still need them in the face of Trikafta? And what was remarkable this study, I think it now has over 500 patients in the study enrolling during a pandemic. So when much of research stopped, this study kept rolling, and it did so safely, and it did so because of a committed CF community and CF patients. And we have patients in this study here at the University of Washington, and I can't wait to see the answers, because I think it can help guide us to say, maybe we can really simplify the burden of care that patients are now have experienced for decades. Can we safely take away these drugs? And if we do their lung functions, is lung function preserved? But I do want to mention one of the, we're not done in CF research, and I think and it's very clear we're not done. And in 2019, the CF Foundation started what they termed the CFF Path to a Cure, and they have committed to invested $500 million in this investment, and this investment is really to go to the next level. It has been tremendous success up to date. There's still 10% of our patients who are not on modulators, and there's still a number of patients who we have not fully cured of their disease in any way. We've markedly improved it. But there are three big challenges and strategies they're going to try to use. And one is to repair a broken CFTR protein, and this may be more therapies like Trikafta that may work for a number of different mutations, and may even see drugs that are better than Trikafta. The next one is to restore CFTR protein when none exists. And this is very important. A lot of patients have mutations that produce no protein. So these modulators just don't work in that setting. And they're approaching this in a number of exciting ways. And the last would be fixing or replacing the underlying genetic defect. And these are all, I think, to really get at the root cause of CF, which is this abnormal DNA and abnormal protein. And these approaches will be new and novel CFTR modulators. They'll probably use what's called messenger RNA therapy, which is bits of translated DNA that sort of bypass the mutated protein or fix the mutated protein, the RNA that makes the protein, gene therapy and gene editing. And I think there's a lot of excitement in gene therapy and gene editing. It had been a very discouraging area for CF research for quite a while. After failures of the late 1990s, there have been great successes in gene therapy. There's a genetic eye disease that is now cured, that leads to blindness, that's now cured by gene therapy. There's a gene therapy for an abnormality of blood fats that you inject into the thigh, and it cleans your blood of these abnormal lipids and reduces your risk of early and severe heart disease. And there are also some exciting new mRNA therapies that seem to be working. So there's been a lot of advances since the early era of gene therapy. And so there's a lot of interest in figuring out how to solve this problem for CF. But I think that there's still a lot of work to do in CF. I think we can say that we've come a long ways, but we want to be at a place where every CF patient has a normal life expectancy and lives a normal life, and hopefully a normal life not burdened by all the treatments that have gotten us to where we are now. That is a simple treatment that actually makes sure that their future is the same as someone who doesn't have CF. And I still think how far we've come is extraordinary. I would have never predicted we'd get to where we are now after doing this for 20 years. But that sort of makes me think that I think anything is possible. And what really makes this possible is sort of a really extensive commitment by the CF Foundation to solving this problem. So with that, thanks for your attention. This This is a picture of, this is in the Dolomites where you don't get to go right now. This is in northern Italy, a place I've gone hiking and I just love it. For anyone in the Northwest, this is a wonderful place to be. I walked around this big chunk of rock in about a day. But it's, we hope maybe we'll all be traveling again in the future. But I wanted to sort of acknowledge help I got in this presentation. One is Moira Aiken. She's our center director and been our center director here at the Adult Center since 1991. Ajay Dandekar and Kathy Ramos are my colleagues in CF Clinic, an adult CF clinic. And Pradeep Singh is one of our physician scientists here who studies pseudomonal biology and also sort of novel ways to fool and trick and treat Pseudomonas. And then Bonnie Ramsey, who I still meet with once a week, who's here at Children's, no longer seeing patients, but doing research. Dave Nichols, who is I think about to become a professor of pediatrics, but sees kids at Seattle Children's. And then Nicole Hamlet is a statistician. And then Margaret Rosenfeld, a pediatric pulmonologist whose work in infant and children lung function and treatments has been extraordinary over time. So, and then the CF Foundation, I started working with the CF Foundation when Bob Bell was the president, then Preston Campbell, and now Mike Boyle. And then the person who heads up the therapeutic development group is JP Clancy. So with that, happy to take any questions.
Thank you. Oh, sorry. Thank you so much. It doesn't look like we have any questions, but there are a few comments just saying how you are making a grandma and grandpa feel very hopeful and that you're helping to lead CFF up the mountain to a cure, and they're just so happy. So thank you so much. We know how busy you are, and you always answer the call when we ask you to present on something, and always make yourself available.
Well, it is my pleasure, and I hope you guys have a lovely day. This is obviously, I love your lineup of talks, and I love this I'd love to be in person, but it seems like you can reach a lot of people by doing this virtually. So
yeah, it's really a great opportunity, right, for everyone to be able to jump on. So I think we may even keep this going back when we get back in person.
Well, thanks very much for having me.
Thanks, Dr. Goss.
Take care.
All right, everyone, we are on our last speaker, last but definitely not least. We have Dr. Ricker, who's going to be speaking on CF testing in transition. Dr. Ricker is a board certified in pediatrics, pediatric pulmonology, and sleep medicine. He has been part of Pediatrics Northwest in Tacoma and practicing at Mary Bridge Children's Hospital for almost 30 years. Along with Dr. Larry Larson, he is the co-director of the CF Affiliate Center. He is a clinical professor of pediatrics at the University of Washington. He is proud to be married to Brenda. He has 6 children and 3 grandchildren. And one of his favorite things to do is enjoy the natural beauty of the Pacific Northwest. Thanks so much for being with us, Dr. Ricker.
Well, thank you, Jillian, for that nice introduction. Let me see if I can share my screen. Okay, are you seeing my screen? Are you seeing my screen?
Yep, we can see.
Okay, great. All right. So, so what we're going to talk about is, this is a much more basic talk than Dr. Goss's. And for those of you who have been around CF for a long time, this may be things that you're already familiar with. But, you know, so much more happens when you come to CF clinic, aside from just getting a history exam, seeing how things are going. As I think people are familiar with, there's lots of tests, from blood tests, lung function tests, to microbiology tests, radiology tests. I just wanted to provide an opportunity to kind of talk some about some of that and the rationale, and certainly provide an opportunity to ask questions. You know, the second topic is transition, which for this topic has nothing to do with sex and gender, but everything to do with the fact that, you know, typically diagnosis of cystic fibrosis takes place, you know, in the newborn or early childhood period. And, you know, parents are told, you know, all about CF and how to care for their child. And then, you know, a couple of decades later, you know, that person has, that was coming to CF clinic on their own, is a, you know, a job, may have a family. And so how do we get from one place to the other place seamlessly. And you know, if there's adults on the call with CF, you know, you may be pretty familiar with this, and I would welcome any kind of input, either positive or negative, in terms of how, you know, transition from being cared for to caring for yourself has gone. So the what, the when, and the why includes cultures we take, lung function or spirometry, radiographs, the annual labs, and glucose tolerance test and DEXA scans. So let's start with the culturals. These should occur at least quarterly. You know, for young kids, typically it means a throat swab, what we call an oropharyngeal culture. Ideally, as soon as sputum can be produced, it's better. Sometimes we'll get microbiology cultures directly from the lungs via a bronchoscope with bronchoalveolar lavage. You know, these specimens, by mandate of the CF Foundation, and this has gone over every time we have these site visits, these cultures are not treated like any other cultures. The lab has specific instruction that these cultures come from somebody with CF, and so they have to be processed, you know, differently, looking for specific bacteria. So the way that cultures are helpful basically is if symptoms arise, if you need to call your care team because you're coughing, producing more sputum, having respiratory symptoms, your care team can, look back on the record and see what's grown in previous cultures and tailor the antibiotics or antimicrobial therapy just towards what we have evidence that's been in your lungs previously. That's one reason. The other reason is more of a surveillance role, looking for new airway bacteria. Usually this is looking particularly for Pseudomonas, may also be looking for bacteria such as methicillin-resistant Staph aureus. And those are cases when we may want to, regardless of symptoms, treat with a course of antibiotics, perhaps a course of inhaled tobramycin, with the goal of eradicating that bacteria. And lastly, the cultures are done in a kind of a routine fashion, but also if sputum is produced, we like to not send for regular culture. In addition to just sending for regular cultures, we'd like to send for mycobacterial cultures. Mycobacteria are a whole different family of microorganisms. Tuberculosis is in that family, although that's typically not what we're looking for. And if you're taking azithromycin, 3 times a week, getting the mycobacterial cultures on a regular basis, usually every 6 months, is important. Okay, spirometry. I think most people are familiar with PFTs, which should occur at least quarterly, has been our practice. And a lot of what I'm saying it applies to our approach at Marybridge, but I think is common through most CF centers. When we do spirometry, we get a lot of numbers, typically lung volumes measured in liters, or also flow rates, which are measured typically in liters per second. We start having kids do spirometry or lung function. We start doing it at about age 4, and sometimes surprisingly, we have 4-year-olds that can do a great job, but we don't necessarily expect that's going to be true. So it might be a practice time. Typically, by the time a child is 6 years of age, we expect they're going to be able to do a reliable PFT. Doing spirometry is effort dependent. We have some clues. We can tell whether or not it's best effort or not, but you have to be really trying to get a good test result. Spirometry it's widely regarded as the best measure of pulmonary function, and for so many research endeavors in the field of CF, the FEV1 is an important outcome measure. That stands for forced expiratory volume in 1 second. So that's, if it's reduced, that's an indicator of airway obstruction. If I were to say we're looking at one thing in terms of lung function, that would be it. but we do look at the other results. And then there are some other types of testing that might occur in some centers. We previously have done impedance oscillometry in patients. The advantage of that is you can do it down to 3 years of age. We've done that in the past, but right now our machine is broken. We're expecting a new one. Some centers have practiced lung clearance index testing, which is more of a research tool as I understand it right now, but may become more widely available. It's a nice way to measure out how the lung empties. Okay, and then radiographs. Typically, our approach is to do a chest x-ray every 2 years, which can provide a lot of information, but very often chest x-rays really don't provide as much information as we would like. Some centers have really advocated that chest CT scans should be done routinely, perhaps every 2 years. And there's a pretty decent argument for that, in that chest CT scans can provide so much more information about lung health than a regular chest x-ray. So much more in terms of pathology could be identified. Problems with chest x-rays would be that, CT scans would be that they're more expensive. There are a lot more radiation, and this is a potential concern that can come up if chest CT scans are being done repeatedly. And certainly for young children would require sedation. We don't do chest CT scans at Marybridge routinely. Typically, MRI or magnetic resonance imaging, which does not involve radiation, typically that has been a pretty poor modality in terms of looking at the lungs, but that's changing, and there's some ongoing work in that. In the future, MRI may be a very valuable tool in terms of imaging the lungs. Okay, the annual labs, what happens on the once-a-year blood test? We do a CBC, which is a screen for anemia. Overall, it's a way to make sure that the bone marrow is functioning properly. Comprehensive chemistry panel, typically this will look at 16 or 20 different items. Can look at the electrolytes, the liver and kidney function, bone health. Certainly the liver is commonly affected in CF, very common in fact, although in most people it's probably only something that you would see if you were to take a small bit of liver tissue under a microscope. But we're looking for changes in enzymes associated with liver function. We look at vitamin D levels, specifically vitamin A, E, and D. GGT is gamma glutamyl transferase, which also is another way of looking at liver function. IgE stands for immunoglobulin E, and it's a screen for allergic bronchopulmonary aspergillosis, which can affect people with CF and asthma and other lung disease. It's basically a type of allergic reaction in the lungs involving aspergillus, which is a common fungus that's all around us. And then, of course, urinalysis is a way to measure kidney function. Glucose tolerance test is something that we recommend. I know there was a previous talk, and so I hope I'm not being too repetitive. Typically, we'll recommend the glucose tolerance test starting at 10 years of age, although there's a higher risk in Hispanic population, so that we start doing that at age 5 and yearly in Hispanic population. Sooner, if there's clinical concerns, if somebody's not gaining weight well, or there's a lot of lung disease, or if somebody is on a lot of steroids for one reason or another. Typically, glucose tolerance test means measuring fasting blood sugar, then drinking 8 ounces of a syrupy glucose solution, which contains 7 75 grams of sugar, measuring the blood sugar 1 hour and 2 hours later. If women who are pregnant typically go through this as part of their pregnancy and may be familiar, it's a screen for gestational diabetes. And the glucose tolerance test is looking for CF-related diabetes, or actually precursors or early signs. Before we make a diagnosis of CF-related diabetes, we might make a diagnosis of CF-related glucose intolerance. Okay, oh, let's see. Oh, okay, we'll get back to the other slide. So DEXA scans are, it's a way to evaluate bone health. It's also called bone densitometry. It's used to identify reduced bone density, which means a higher risk of fractures. Our routine is that it should be done by 18 years of age at the latest. Some people suggest it should be done as early as 8 years of age. And this is especially if there's risk factors such as lots of steroid use, poor lung function, poor nutrition, poorly controlled diabetes. And then depending upon the results, depending upon the age and overall health, DEXA scans should be repeated every 1 to 5 years. So that's it in terms of talking about labs, and I think I'll finish in time if there's any questions. So basically the next topic, the whole transition, which is basically kind of what happens when our son and daughter grows up, with CF. Are they going to be able to manage their CF? So transition here is defined. It's a gradual process of increasing responsibilities in self-care and disease management, an improvement in the understanding of CF, and an iterative or repetitive gradual process of self-assessment with knowledge acquisition. So, the question that has been asked at plenty of CF meetings that I've been to and among ourselves as a team is just, how do we do this well? And a lot of people have studied this a lot. I can share some of our own approach and experience. I mean, probably the first most important thing is having that conversation with parents and with patients, preferably starting early, even 10 years of age. One approach that we have done and used in the past, and I'll share what we're doing right now, but we've used checklists that we try and address at different visits, and we'll have different team members involved in this for different expectations at different ages and stages. The goal is that the child or adolescent is taking on more and more responsibility as they age and as they have more developmental maturity. One example of this would be, determining a point in time, and we've often set 14 years of age at a time where we would have the adolescent come back to the exam room by themselves, and they, of course, get weighed and measured, and they do their PFT, and then the adolescent teenager gives the history, they get the exam, and then the care provider provides feedback and talks and reflects. And then you bring the parent back and talk about, okay, how is Johnny doing? What are we going to do next? What's the plan? I'm going to go back to that a slide that we somehow got in there. Basically, transition is kind of it's a transfer of responsibilities where you think about the person with CF starts off in a depending pattern, then becomes is more engaged in their care. As they get into the early high school years, they're more involved in managing their own CF, and then leading that management of CF to the point where in early adulthood, they're owning their own CF care. Likewise, the parent's role changes from providing and teaching, to managing, to then delegating and monitoring, then assisting and supporting. Okay, so a tool that we have used and I found really helpful is the CF RISE program. RISE stands for Responsibility, Independence, Self-Care, and Education. And basically it's a web-based program that provides knowledge assessments, and this is kind of geared towards different ages, and also responsibilities checklists. And this is something that right now we're using. It's primarily Barbara Guerrero, who's our CF Center social worker, who will introduce this to patients and family. We provide them with a log on, and they can typically will at one of the visits will help them log on, create an account, and then do one of the knowledge assessments with them. And then they're free to kind of do as many on their own. This is my last slide, and it just provides an example of the knowledge assessments that you can see there. I mean, this is in small print, but the first few are lung health and airway clearance, pancreatic insufficiency and nutrition, CF in your body, CF general health, screening and prevention, CF equipment, and infection control. And so it is designed to be used or at least introduced by a CF team member. And we've had a lot of good feedback, and I think this has been helpful for a lot of patients. So I'm going to stop sharing my slides there. Any questions, any comments?
I mean, we got a few I love Dr. Rickers.
Oh, okay.
It doesn't look like we have any questions at the moment.
Okay.
Thank you so much for joining us, Dr. Ricker. I know that we got a hold of you last minute, and it was so kind of you to come in. I'm sure you have other things going on this weekend. Thank you for being with our community and teaching everybody.
Yeah, happy to help out.
All right, everyone. So, I mean, I think I just want to kind of reiterate that we are so lucky to have such a wealth of knowledge in Washington, Alaska, and healthcare professionals that care so much. So thank you again to all of our CF clinics, Providence, Alaska, Seattle Children's, Providence, Spokane, UW Adult Clinic, Marybridge, Tacoma, our incredible presenters for sharing their time and expertise with us, and all of you for joining in. We are going to put up a recording of this webinar sometime next week. I'll be happy to email out the link to everyone who registered. And that way you can look back on anything you might have missed or share it with others. And with that, if we don't have anything else, I will tell you have a great weekend, and we hope to see all of you guys at Great Strides. Thank you very much.